So the management of the newborn should focus on parental anticipatory guidance and early detection of conditions or complications that carry risk of morbidity or even death. The assessment of the newborn should begin with a review of the maternal and family history, the pregnancy, and the delivery. Details of this history should include the demographic and social data, which includes the socioeconomic status, the age. For instance, if the mother is more than 30 or 35 years old, this poses increased risk for infants to have genetic disorders such as trisomy 21. Additional information regarding the race, prenatal care, utilization of substances, and maternal medical conditions such as cardiopulmonary disorders, infectious diseases, genetic disorders, anemia, diabetes mellitus, and medications taken should also be asked since some medications pose atherogenic effects for newborns. Newborns of diabetic mothers warrant screening within the first 24 hours of life for severe hypoglycemia. So the past medical illnesses in the mother and in the family should also be noted. Previous maternal reproductive problems such as prematurity, stillbirth, ABO incompatibility, and events occurring during the present pregnancy that will prompt additional newborn testing. So we also need to take note the description of the labor and the delivery, such as if there was a rupture of membranes, prolonged labor, use of assistive devices such as forceps and vacuum that will help determine the risk for clinical deterioration and the need for further monitoring and intervention. So the initial examination of the newborn infant should be performed as soon as possible after delivery, which assesses if the newborn has spontaneous breathing, the Apgar score, if the newborn had cord coil, any signs of meconium stain, and we should also take note of the vital signs. After a stable delivery room course, a second and more detailed examination should be performed within 24 hours of birth. Examining a newborn requires patience, gentleness, and procedural flexibility. If the infant is quiet and relaxed, auscultation of the heart and lungs and palpation of the abdomen should be performed first and more intrusive manipulation performed later. Infants should not be discharged from the hospital without a final examination because certain abnormalities, such as cyanosis and heart murmur, often appear or disappear in the immediate neonatal period, and evidence of disease that just has been acquired may be noted. So in this table, this shows the normal value of the vital signs monitored in newborns. So BP is not routinely taken unless there are signs and predisposing factors associated with circulatory problems. So it is illustrated in this picture how to assess for the APGAR, the appearance, the pulse, the remains, activity, and respiration. So the APGAR scoring is used to assess the need for resuscitation in a newborn, but I will not delve into this further because it is already discussed by Dr. Elia. So this in this illustration, this is the Ballard scoring or maturity rating that is used for maturational assessment of gestational age. Its accuracy is minus 2 weeks the actual gestational age. So there is a higher risk for mortality or morbidity if a discrepancy exists between the estimation of gestational age by examination, the mother's estimated date of her LMP, and the fetal ultrasound evaluation. For extremely preterm infants, they should be scored within the first 12 hours of life, while full-term infants are scored as early or within 72 hours. It is then divided into the physical and the neurological maturity. So the scores are added and the sum calculates the gestational age. As you can see here on the lower portion of the illustration. So the neuromuscular maturity comprises the following: the posture, the square window, the arm recoil, the popliteal angle, scarf sign, and field to ear maneuver. So the birth weight, the length, head circumference, and chest circumference are plotted against gestational age on standard growth curves. We also classify neonates based on their birth weight and birth weight versus their gestational age. So for the birth weight, we classify them if they are less than 2,500 grams, they are considered low birth weight. For less than 1,500 grams, they are considered very low birth weight. And for those less than 1,000 grams, they are labeled uh, extremely low birth weight. For the birth This gestational age, we label them if they are small for their gestational age, if they are appropriate for their gestational age, and if they are large for their gestational age. So, physical activity may be decreased by the effects of illness or drugs. An infant may be either lying with extremities motionless to conserve the energy for the effort of difficult breathing, or vigorously crying with accompanying activity of the arms and legs. So, both active and passive muscle tone and any unusual posture should be noted. Generalized edema may occur with prematurity, hyperproteinemia, secondary to severe erythroblastoma fetalis, non-immune hydrops, congenital nephrosis, while localized edema may suggest congenital malformation of the lymphatic system. If it is confined to one or more extremities of a female neonate, it may be an initial sign of Turner syndrome. We should also take note of the following sa skin. Acrocyanosis is a vasomotor instability and peripheral circulatory sluggishness that are revealed by deep redness or purple lividity in a crying infant whose color may darken profoundly with the glotis preceding a vigorous cry and by harmless cyanosis of the hands and feet, especially when they are cold. Mottling is another example of general circulatory instability and may be associated with serious illness, or it could be related to a transient fluctuation in skin temperature, often called as cutis marmorata. So a transient and harmless condition called the harlequin color change is an extraordinary division of the body from the forehead to the pubis into the red and pale hats. Jaundice is mostly not apparent in less than 12 hours of life, but I have included it here just for reference. So, a significant cyanosis may be masked by the pallor of circulatory failure or anemia. Alternatively, the relatively high hemoglobin content of the first few days and the thin skin will combine to produce an appearance of cyanosis at a higher partial pressure of oxygen, arterial oxygen. Localized cyanosis is differentiated from ecchymosis with a momentary blanching pallor with cyanosis that occurs after pressure. So for pallor, it may be caused by anemia, asphyxia, shock, or edema. Early recognition of anemia may lead to a diagnosis of fetal-maternal blood transfusion, fetalis, subscapular hematoma of the liver or spleen, subdural hemorrhage, or fetal-maternal hemoglobin transfusion. So for the vernix, it is a waxy or cheese-like white substance found coating the skin of newborn human babies and functions mostly for thermal regulation. Secondary hemangioma or the strawberry birthmark is a benign or non-cancerous tumor consisting of an abnormal overgrowth of tiny blood vessels. It may not be present at birth but appears within the first 6 months of life. Cutaneous hemangioma. These are deeper tiny masses that, if large, may trap platelets and produce disseminated intravascular coagulation or interfere with local organ function, which is much more dangerous than the capillary hemangioma. So for the Mongolian spot, it is a flat blue-gray with well-defined margins seen over the buttocks, the back, and sometimes in other parts of the body, and tend to disappear within the first year. So birthmarks, like in this baby, we should also take note where the birthmark is and the shape of the birthmark. So for the skin of premature infants is thin and delicate and tends to be deep red, and in extremely premature infants, the skin appears almost gelatinous and translucent, as you can see on this illustration. So post-term infants may have a peeling parchment-like skin, as noted in the picture on the far right side, a severe degree of which may mimic ichthyosis congenital. To continue, the lanugo is a fine, soft, immature hair that frequently covers the scalp and brow, and also cover the face of premature infants. It is usually replaced by villous hair in term infants. Also take note if there are tufts of hair over the lumbosacral region, which suggests an underlying abnormality such as spina bifida occulta, a sinus shock, or a tumor. Uh, are small white papules on an erythematous base that develop 1 to 3 days after birth. It is a benign rash that persists for as long as 1 week and contains eosinophils and is distributed on the face, trunk, and extremities. For pustular melanosis, it is a benign lesion that are seen prominently in black neonates, which contains neutrophils and is present at birth as a vesiculopustular eruption around the chin, the neck, the back, extremities, and palms and/or soles, and lasts for 2 to 3 days. So both lesions need to be differentiated from herpes simplex and staphylococcus disease of the skin, which are more dangerous. For the neonatal acne, they have open and closed comedones from circulating androgens and usually resolves on its own. So for the milia, these are small inclusion cysts, poorly wide in color and usually located on the face. For the skull, we need to take note if the fontanelles are open, and they are usually open and flat and both the anterior and the posterior fontanelles. So we also need to take note of the following and differentiate this from the other uh, skull findings. The caput subcutaneum. This is caused by skull pressure from the uterus, cervix, or pelvis and appears as a circular boggy area of edema which is indistinct borders and often with overlying ecchymosis. It crosses the suture line and usually results in bleeds. The subgleal hemorrhage is not restricted by the boundaries of the sutures and therefore is larger and more diffuse. It is beneath the epicranial aponeurosis and may extend to the orbit concave. It requires prompt treatment because excessive bleeding may result in hypovolemic shock with estimated mortality of up to 20%. This usually resolves in 2 to 3 weeks as well. So for the cephalhematoma, it presents as a well-circumscribed fluid-filled mass that does not cross suture lines. This is often not present at delivery but develops over the first few hours of life. It is located subperiosteally. There is no edema or discoloration of the scalp and resolves in 2 to 3 weeks. You should also take note of the head circumference. Circumference should be plotted to identify an excessively small head or the microcephaly or excessively large head or the macrocephaly. So microcephaly can be caused by genetic disorders, congenital infection, and intrauterine drug exposure. So for the macrocephaly, it can suggest hydrocephalus, storage disease, achondroplasia, cerebral gigantism, neurocutaneous syndromes, or inborn errors of metabolism, or it may be familial. So for the craniosynostosis, it is the premature fusion of sutures and is identified as a hard, non-movable ridge over the suture with an abnormally shaped skull. For craniotabes, these are soft areas found in the parietal bones near the sagittal suture and more common in preterm infants or those who are exposed to uterine contractions. Soft areas in the occipital region suggest the irregular calcification and Boomian bone formation associated with osteogenesis imperfecta, pedicranial dysostosis, lacunar skull, cretinism, and occasionally Down syndrome. Atrophic or alopecia scalp areas may represent acute congenital, which may be sporadic, or autosomal dominant or associated with trisomy 13, chromosome 4 deletion, or Johansson-Bizard syndrome. The formational pliocephaly may be the result of an in-utero positioning which forces on the skull and manifests as asymmetric skull and face with ear malalignment. It is associated with torticollis with vertex positioning. So for the face, the general appearance of the face should be noted with regard to dysmorphic features in the epicanthal folds, widely or narrowly spaced eyes, microphthalmos, asymmetry, long philtrum, and low set ears, which are often associated with congenital syndromes. They often open spontaneously if the infant is held up and tipped gently forward and backward. This results from the labyrinthine and neck reflexes, which is successful maneuver in inspecting the eyes. Pupillary reflexes are present at 28 to 30 weeks age of gestation. For the conjunctival and retinal hemorrhages, these are usually benign and are more common with vacuum or forceps assisted deliveries, which are bilateral. intraretinal, and in the posterior pole usually resolves by 2 to 4 weeks. So the iris should be inspected for colobomas and heterochromia. Coloboma is a congenital malformation of the eyes causing defects in the iris, lens, or retina. The aneurysma is the absence of the iris, as you can see in this picture. And if you note a cornea is more than 1 centimeter in diameter or there is corneal clouding, this suggests congenital glaucoma and requires prompt ophthalmologic consultation, as well as for leukocoria. This is the white pupillary reflex, which suggests cataract or tumor chorioretinitis, retinopathy of prematurity, or a persistent hyperplastic primary vitreous, which also warrants immediate ophthalmologic consultation. Ears, the normal ear position, we also need to take note of this. So we need to have an imaginary line joining the medial canthi and perpendicular to the vertical axis of the head. Deformities of the pinna are occasionally seen. So we can note for skin tags on the ears as well. For the nose and mouth, so newborns are obligate nose breathers. The nose may be slightly obstructed by mucus accumulated in the narrow nostrils. That is why nasal suctioning is needed. The nares should be symmetric and patent. Anatomic obstruction of the nasal passages secondary to cranial atresia results in respiratory distress. So you should assess this by inability to pass a feeding tube through the nares. Though the latest guidelines for EIMC does not recommend suctioning, not unless there is evidence of thick meconium stain amniotic fluid. So for the precocious dentition, or with natal or neonatal teeth in the lower incisors position are abundantly placed. These teeth are shed before the deciduous ones adopt. Such teeth occur in Ellis van Creveld, Hallerman's Drift, and other syndromes. Extraction is usually not indicated, but may be removed to prevent aspiration. So for the soft and hard palate, it should be inspected or palpated for a complete or submucosal test, and the contour noted if the arch is excessively high or if the uvula is bifid. So epstein pearls are temporary accumulations of epithelial cells. The tongue appears relatively large and frenulum may be short. We call this tongue tie, but its shortness is not a reason for cutting it. If there are problems with feeding, phenotomy may be indicated. So the throat of the newborn is difficult to see because the low arc of the palate. It should be clearly viewed because the stereopalatal or uvular clefts are easy to miss. For the neck appears relatively short. Abnormalities are uncommon but may include goiter, cystic hygroma, brachial cleft cysts, which are incomplete closure of brachial cleft and are found lateral or anterior to the sternocleidoid muscle. Others include teratoma, hemangioma, and lesions of the sternocleidoid muscles that are presumably traumatic or caused by fixed positioning in utero that produces either hematoma or fibrosis respectively. So for the congenital torticollis, discusses the head to turn toward and the face to turn away from the affected side. A redundant skin or webbing of the neck, especially in females, may suggest Turner syndrome. So we also need to take note of the clavicles. This needs to be palpated for fractures, especially for difficult deliveries. For the chest, breast hypertrophy is common due to maternal hormones, and which milk may be present but should not be expressed. Asymmetry, erythema, induration, and tenderness such as mastitis or supernumerary nipples may be associated with anomalies. It should also be noted if there are inverted nipples or widely spaced nipples may be seen. A shield-shaped chest suggests Turner syndrome as well. We should also take note if there is pectus carinatum and pectus excavatum in our babies. So the breathing of newborn infants at rest are fairly diaphragmatic. In inspiration, the thorax is drawn inward while abdomen protrudes. The breath sounds are usually bronchovesicular. The normal variation in rate and rhythm are characteristic and fluctuate according to the infant's activity, the state of wakefulness, or the presence of crying. Because fluctuations are rapid, RR should be counted for a full minute, preferably in resting state or asleep. The usual RR for a term newborn is 30 to 60 cycles per minute. In preterm or premature infants, the rate is higher and fluctuates more widely. A rate consisting of more than 60 cycles per minute during periods of regular breathing that persists for 1 hour after birth is an indication to rule out pulmonary, cardiac, or metabolic disease etiologies. So, preterm infants may breathe with kind strokes rhythm, also known as periodic respiration, with short pauses in breathing, not more than 10 seconds, followed by rapid shallow breaths, accompanied by minor saturations or bradycardia, or preterm infants may also breathe with complete irregularity. Irregular gasping accompanied by spasmodic movements of the mouth and chin strongly indicates serious impairment of the respiratory system. So, labored respiration with retractions is an important evidence of respiratory distress syndrome, pneumonia, anomalies of mechanical disturbance of the lungs. A weak, persistent, or intermittent groaning, whining cry, or grunting during expiration can signify potentially serious cardiopulmonary disease or sepsis, which warrants immediate attention. So, suspicion of pulmonary pathology because of diminished breath sounds, bronchi, retractions, or cyanosis should always be verified with a chest radiograph. The location of the heart should be determined to detect dextrocardia. If the eye is located at the fourth left ICS, changed location may be seen in pathologic conditions such as pneumothorax. The heart rate is usually 110 to 140 beats per minute at rest and may increase to 180 beats per minute during an activity. Preterm infants usually have a higher resting heart rate, 160 beats per minute, but may have sudden onset of sinus bradycardia secondary to apnea. So pulses need to be palpated in the upper and lower extremities to detect coarctation of the aorta, in which there are stronger pulses in the upper extremities than the lower extremities. Transitory murmurs occur usually usually present or usually represent a closing ductus arteriosus. Innocent murmurs are usually soft and vibratory and sometimes intermittent. Pathologic murmurs associated with the frail, loud, which is louder and heard over a wide area of the chest. For the abdomen is slightly protuberant. The umbilical cord should have two arteries and one vein. A single umbilical artery has an increased risk for an occult renal anomaly. The stump usually sloughs off by 2 weeks of life. So the liver is palpated 2 centimeters below the rib margin. The approximate size and location of each kidney can be determined on blood palpation. The abdominal wall is usually weak, and diastasis recti and umbilical hernias are common, particularly in black infants. Unusual masses should be investigated immediately with ultrasonography. So, renal pathology is the cause of most neonatal abdominal masses. Cystic abdominal masses include hydronephrosis, multicystic dysplastic kidney, adrenal hemorrhage, hydrometalocolpos, intestinal duplication, and choledochopal, ovarian, omental, or pancreatic cyst. Solid masses include neuroblastoma, congenital mesoblastic nephroma, hepatoblastoma, and teratoma. So a solid flank mass may be caused by renal vein thrombosis, which becomes apparent with hematuria, hypertension, and thrombocytopenia. This is associated with polycythemia, dehydration, maternal diabetes, asphyxia, sepsis, nephrosis, and hypercoagulable states. So the abdominal distension at birth or shortly afterwards suggests obstruction or perforation of the GIT. The later distension suggests lower bowel obstruction, sepsis, and peritonitis. The scaphoid abdomen suggests diaphragmatic hernia, in which bowel sounds could be auscultated over the chest wall. So the abdominal wall defects such as gastroschisis is a full thickness abdominal wall defect that is laterally located to the umbilicus. So compared to the omphalocele, in which the abdominal contents herniate into the base of the umbilical cord, and covered by a protective membrane. The omphalocele is associated with other anomalies or syndromes. So we should also take note if there are signs of omphalitis or which is in the infection of the umbilical stump from umbilicus. Uh, it can have redness, edema, foul odor, discharge. Um, but usually we don't see this after birth. I've just mentioned it here for reference. So voiding must be within the first 24 hours of life. The genitals and mammary glands normally respond to transplacentally acquired maternal hormones to produce enlargement and secretion of the breast in both sexes and prominence of the genitals in females, which usually does not require intervention. So imperforate hymen may suggest an inhydrometocolpus from vaginal outflow obstruction and accumulations of secretion secondary to transplacentally acquired maternal hormones. For male infants, we should need to inspect the phallus and try to retract the prepuce to view the urethral orifice. The prepuce is normally tight and adherent to penile glands and cannot be retracted. Severe hypospadias or the urethral orifice located on the ventral surface of the shaft or epispadias suggests presence of abnormal sex chromosome of the infant and is actually a masculinized female with enlarged clitoris, which may be the first evidence of an androgenital syndrome. For the we should also take note if is a hydrocele for male infants. There is a narrow opening which allows peritoneal fluid to leave the abdominal cavity and accumulate in the scrotum. It is distinguished from hernia by entrance illumination, as you can see in this picture. The scrotum may be increased in size due to trauma from breech presentation, and the testes should be palpated uh, in the scrotum or in the canals in term infants. So, for the passage of the meconium usually occurs within the first 12 hours of birth. So we should also take note if there is an imperforate anus and in imperforate anus, the anal penis is absent or incorrectly located. So, however, if there is a fistula to the skin, urethra, or vagina, a newborn can pass meconium, and imperforate anus may not be suspected unless a careful examination is done. For females with imperforate anus, careful examination of the vestibule must be made to ensure separate openings of the urethra and vagina. All newborns with anorectal malformation warrant evaluation for possible cardiac, renal, and spine anomalies that are associated with imperforated anus. So for the hands and feet, these should be examined for polydactyly, syndactyly rather, and abnormal dermatoglyphic patterns such as simian crease. Severe positional deformations and contractures produce polyposis, which describes congenital joint contracture in two or more areas of the body. Other manifestations of fetal neuromuscular disease include breech presentation, polyhydramnios, failure to breathe at birth, pulmonary hypoplasia, dislocated hips, undescended testes, thin ribs and club foot. Many congenital disorders manifest as hypotonia, hypertonia, or seizures that we also need to take note when examining the newborn infant. So that would be the end of my presentation. Thank you po.